Yay! This is so awesome. Welcome in to Killer EKGs, you guys. We're about to get started. We are just getting ready to go live in the Facebook group, so you can watch there and here if you want to. So welcome in for you who are on Zoom. I think there's still a little bit of room on the Zoom. So maybe Ruben, you could post the link in the feed if people want to hop on Zoom. But let me make sure we're in the right place, and then we're going to go ahead and get started with our Killer EKGs class. I can't wait to show you guys all of the things. All right, let's make sure we are here, and we are. All right, awesome. So let me go ahead and share my screen. We'll get our slides ready. So right at 4:30, we are ready to go. Okay, so let's just see a quick little list of who's here with us on Zoom. Hey, Amy, we have lots of Amy's. Andrew, Anna Maria, Brian, lots of Brians. This is awesome. Oh my gosh, so many awesome people are with some Todds. We have Sandra, Sean, Rowena, Robert, hello. Nuria, always nice to see you. And Michelle, let's make sure we get you to panelist. We have our coach, Michelle Barkley, in the house. So cool, I think we're almost on time and we should be all ready to go here in just a minute. So what we're going to talk about tonight is the things that we can't afford to miss on the EKG. And I'm really excited because I'm not going to hold anything back tonight. I'm going to share with you guys some things that you really need to know that you may not have ever heard about before tonight. So don't be shocked if you're like, ooh, I better go look that up after you're done. And that's okay. But we're gonna show you this article that came out that's gonna really be a game changer. Okay, awesome. So now that we are right on time, let's officially kick this off and welcome into Killer EKGs. My name is Jen Carlquist. This is gonna be about an hour masterclass, and I'm a PA, have been one for, I counted it up the other night, 16 years, both in cardiology and emergency medicine. Hey, Gus from New York, welcome in. And so I'm going to share with you tonight a couple things that got us to the place that we are in our EKG world. But then I'm also going to show you the way to get out of it. And I'll explain that more in a minute. But if you want to, like Gus just did, type in the chat where you're coming in from. Put the city, if you don't mind. We like to know where you guys are all tuning in, especially we have a lot of folks usually on the East Coast. So 4:30 is a better time, I think, for you guys, because you guys aren't eating dinner, right? Yonkers, okay, yeah, lots of North Carolina. Okay, Boston, Richmond, Oklahoma, England, wow. Florida, Madison, okay, Oregon, Detroit, North Dakota. This is awesome. This is really cool. Florida. Okay, so Florida people, I'm going to be coming to do a full day workshop in 2 cities in Florida in September and October. One will be Orlando and one will be Pensacola. Oh, we have a Myrtle Beach. Hey, Rihanna, also coming to Myrtle Beach in the summer in August. Amanda also in South Carolina. So I'll be coming there. If you guys are interested in potentially meeting in person, when I come out your way, Rowena, I'm also coming to Las Vegas in November to do a conference there. So hit me up, I can give you the details. And I would love to even just meet you guys in person. Okay, so welcome in. Let's get this party started. So again, I talked about my long tenure as a PA. I'm trying to, in Virginia, okay. Oh, you've taken the workshop in Myrtle Beach. So awesome that you're here. Well, you're going to love this. It's going to be like a little brush up for you. Although there's been some new changes since we've last met back in, I think it was probably the year before. So lots of new things we're going to talk about tonight. So I'm a former paramedic also of 13 years. And to be honest, I love being a PA, but I love being a paramedic even more. It was such an amazing job. There's not a day that goes by that I don't hear a siren and don't miss it. So if you're a paramedic and you're here, hats off to you. Totally want to live vicariously through you because it's such a great job. And then also I do write for some urgent care journals, and I've written for Journal of America, not Jack, but a couple other magazines here and there. And then I lecture at conferences all over the country. So this is my dog, Remy, and he's sort of our mascot. So he puts on a series called STEMI with Remy. And so you might have seen that. So if you've seen STEMI with Remy or any of his little rhythm quizzes he does, drop that in the chat as well. We put those on the business page. They're kind of fun. But just to give you a little intro, and then we also have Michelle Barkley in the house. And Michelle, you've probably met her previously if you came to our February 3-day EKG challenge. We broke into Zooms, and so you probably are familiar with her as well. So she is hanging out with us tonight also. And we just got the whole crew. And then Ruben, of course, you see him tagging, and he's also here. So we've got everybody in the house here to help you. Okay, now this is a couple of things that we're going to talk about tonight. So I made a little funny magazine cover, and basically the question I want you to ask yourselves is, are you ready for the next chest pain patient? Now, why do I frame it like that? I frame it like that because I remember a time where I used to think to myself, ooh, I'm not ready for the next patient that's got chest pain, right? I don't feel confident with the EKG. I feel like I'm going to miss something. I don't know what to do when the machine software says that thing, that non-specific thing. I don't know what to look for. I don't know who I should send to the ER. I don't want the ER to be mad at me, right? And so in clinic, that's kind of always this fine line we kind of juggle, right? Like, what do we do? What do we do with this gray area stuff? I know what to do with the STEMI. I'm good there. If they're in asystole, yeah, I got that too, right? But it's the gray area stuff. So that's really what we're going to focus on tonight, is identifying those findings, because here's the reality check that I don't think a lot of people know. And that reality check is that there's at least 5 things that the machine will label non-specific that are really dangerous. And they're not teaching it in school. And they're not really even jumping from the rooftops teaching it to us either. So it kind of fell in our labs, and they were like, yeah, and also here's some new STEMI equivalents. So while we should be, right, like someone should be standing on the top of the roof and being like, hey, PAs, NPs, MDs, medics, there's some new STEMI equivalents that you should know about. And here's what they are. And here's, right, no one's doing that. So that's what tonight is about. Hey, Samantha's a medic too. So I live vicariously through Samantha all the time. So we're going to talk about hyperacute T waves. And if you've never heard that, we're going to define it for you. We're going to talk about something called Whelan's warning, which is the LAD, basically the left anterior descending, is telling you it's in trouble. And believe it or not, the heart actually speaks a language. And the language it speaks is it'll bend its T waves, which is what Whelan's warning is. It'll make its T waves bigger, which is what hyperacute T waves are. And it does all these little like signals. It's like Morse code, and we have to decipher what it means. So that's really the trick. But here's the thing that I think makes it so much easier. And that is that these signals, these patterns, once you really memorize them, David White, our EKG Mandalorian, always says they look like faces to him. And they look like faces to me too, because once you see it, you're like, oh yeah. When you see it again, you're like, oh yeah, you, right? But it takes some practice doing that. And it takes understanding the first level, which is what normal is. So on that note, if you want to go back and refresh some of the basics, we still have those recordings up. You can put a little comment here. I'll go back after we get off, and I'll get you a replay page where you can go and replay all 3 nights, where we dug into more basic stuff. But tonight is not basic. Tonight is about, oh my gosh, right? Set the town on fire because there's an emergency going on, and we need to put out the fire. And I'm going to tell you a little bit more about that. But really, if you want to know, like, why am I here? This is my night off. Okay. It's Monday night. This is my night off. Why would I be here on a Monday night when I could be out? I was actually in my garage painting a little bit earlier. Why would I be here? Okay. Yes. You would love a review page. Okay. We'll definitely get that for you guys. So, because if you win, right? And I want more than anything, I want my mid-level or NPs, PAs, I want you to win, because when you win, we all win. And your patient wins. And also we really care. So at the end of the day, it's about all those things. And if you've met me before, you know that my mission is save all the lives. Okay, so save all the lives. All right, you'd like the access to other videos? Cool, we'll definitely get those for you when we're done. So the objectives of tonight is we're going to talk about why EKG reading is high risk. We're going to talk about what we've been taught and why it's not enough, and kind of supplement that a little tonight, and why what we don't know will hurt us, and why we need to spend some time learning these findings, and ultimately what's more important than the EKG. Now, I know if you know me at all, you're like, Jen, what? You don't think anything's more important than the EKG? Well, actually, I do. And I think that the most important thing that we're going to do is patient history and patient's story, and putting that together with gut instinct. Think about this. If you've ever had a case that you can think back on, and you had a normal EKG, and maybe you had a normal stress test, but the patient was like, I exert myself, I get severe pain that radiates to my jaw, to my arm, and I get sweaty, who are you going to believe? It's not going to be the machine. And have I seen nuclear stress tests be wrong? Mm-hmm. Have I seen stress echoes be wrong? Mm-hmm. Have I seen treadmills be wrong? Yep. Have I seen calcium scores, which are a CAT scan of the heart, which I live and breathe by on a normal basis? I've seen them be wrong. It looks like there's a ton of calcification inside the artery, but then you go in with the angiogram and it turns out that it was all on the outside of the artery, right? So Amy says, oh my gosh, yes, I'm a nuclear stress RN and RT. Yeah, you get it. So it has been wrong, okay? So at the end of the day, you guys, this is my, I know we're doing EKGs, but I just want you to marinate in this. Believe your patient first, okay? And if your gut instinct is telling you there is something wrong, keep going and break the tie. I do this all the time. And honestly, the most recent case, we're not going to talk about this tonight, but I had somebody who, she was female, she was in her 50s, and she was like, I have so much chest pain when I walk. And she even said, I really just don't think I can work anymore. And normally that would set off some alarm bells, right? Like for some people, but it didn't for me, because I was like, my gut check, which I trust more than anything, she's telling the truth. And I don't care if there's a normal stress test. Everything was perfect. We still CAF'd her. And thankfully, right, I had a track record with my doc to say, hey, we really need this. And he was like, okay, let's do it. And she ended up having a muscle bridge. This is not something they ever teach us about. What a muscle bridge is it's when an artery on the heart goes underneath part of the muscle and it gets pinched off, and it can present exactly like a heart attack. It's not, right? But they can have the same symptoms. So just because someone doesn't have a blocked artery doesn't mean there isn't something else going on. Okay, so that's the moral of the story tonight. The patient is right. We've got to listen to them. They're trying to tell us what's wrong. Now, the menu EKG findings that you must know. We're going to talk about a new guidelines update, which is more like a consensus document update that was written on, and let me just spoiler alert you right here, okay? It's called a chest pain consensus document on how to manage chest pain in the emergency department. Now, before you tune out in your brain and you're like, well, I don't work at the ER, Jen, I don't need this. Here's the thing. You know that patients don't always present to the right place. They don't always triage themselves appropriately. They don't be like, oh, I have chest pain, I need to go to the ER. No, they show up at primary care. They show up at urgent care. And a lot of times we still have to read their EKG, and we're still held to the same standard. Don't miss the ACS. We have a 0% miss rate. So we still need to know these findings. And that's the problem, is they labeled this article for the emergency department. But then what about us who work in like cardiology or urgent care or primary care, right? What do we do? Right? We don't have to list. No. So that's the real scary thing. And if the lawyers can read these articles, right, and know these guidelines, we should know them too. So we'll talk about that. So we're also going to give away a prize. I'm going to just show you what the prize is. And if you stay till the end, we'll tell you the hashtag to enter to win. And I'll put this in the mail for you if you're the winner. So the prize tonight is actually, this is called an MI window. They don't even make these anymore. Okay. They don't make them anymore. There's actually a tool in here that color codes the EKG for you with contiguous leads and reciprocal changes. These are literally not made anymore. The lady that used to make them, she stopped doing it because she retired. She's like, not doing it anymore. So I have one of these tonight. We'll be giving one away. So we always do prizes. If you've hung around with us for a while, you know, that's kind of how we roll. So I'll give you a hashtag, you'll put it in, and one of you will be lucky enough to win. So, and yes, Michelle says, and our family and friends need to hear this. Tell them, make sure the doctors listen. Amen to that. So I reflected before I did this lecture on what I learned in school, and then what I realized that you also probably learned. And if you were anything like me, you learned about arrhythmias first. You learned about what are called one at a time STEMI. So they gave you an EKG where they showed you just one artery that was occluded. And, you know, maybe some reciprocal changes or contiguous leads, maybe they showed you that. But ultimately, you know, they never showed you any multi-vessel. And then they talked to you and they said, well, you know, the intervals, those numbers at the top of the machine that they print out, they don't even matter. And then they didn't really do any guided practice. And I've heard this story over and over. So tell me in the chat, was that true for you as well? Did you have something similar to this? And was it successful? Because obviously, if we're in this lecture, right, we feel like we maybe need to brush up our skills. We're here because we didn't get enough. Okay. So type in the chat what your experience was. But in the meantime, to my instructors that I learned from, I respectfully disagree with the way that we're being taught EKGs. Because what I also remember from day one was axis and vectors. And while that may seem good on the surface, if you don't have like a physics type of mind to wrap your head around that and how that connects to all the waves, it is a lot. Okay, it was a lot. And so Amy said she learned mainly the basics, AV blocks, and that's it, and ACLS only. Yeah, so it's really, there's this big gap, and that's the problem. So I think that they should have personally spent the time on the things that could kill people. Like, let's really focus on what are the things like HOCM and Brugada and STEMI. These things are going to have high risk implications. If you miss a PAC, nobody dies. But if you miss this other stuff, why aren't we teaching that? Right? So I have honestly not had any courses on EKG. I'm trying to teach myself until I get into my course. Okay. You were always told I have a physician near, and now that I'm in urgent care, physician available, but I need to know. It's very true. And you will, once you see some of these findings tonight, there's a good chance when you go back and you find one of these, your physician you work with may not even know the finding because they're so new, and you could potentially teach them something, which would be fun. I only learned the basics, and half of the stuff I saw, they didn't even talk about in class. Yeah, it's legit. I mean, I know the struggle is real, but thanks for sharing your experiences. So we probably didn't get very many hours. I don't remember how many I got. You probably don't either. It wasn't enough. And it really takes, honestly, it takes some time to be safe. And the reality is that a lot of us are operating at an unsafe level. And I know that to be true because PAs and NPs come up to me all the time at conferences and say, oh my gosh, I feel like I'm an imposter all the time. And it's real, right? So we're going to try to fix a little bit of that tonight. So the basic and STEMI recognition. Okay. I never took any EKG classes. I learned a little bit on the fly. Now that I'm working ER, yes. Okay, good. ER, yes, you have to know these things. So I will say that ER has a little bit higher of a standard to follow. Like, yes, there's a 0% miss rate across the board, but in the ER, because we have all the tools, if we don't use them, we're sort of, it's even a bit bigger miss. So I'm glad you're here, Gus. Okay, so let's talk about how we got here in the first place. If you think about this, you've got this 3D object, and you have to sort of understand how the two go together, a 3D object and a flat piece of paper, 3D flat piece of paper. How do they go together? Well, if you never really understand that, then you're never going to understand EKGs. If you don't understand, we're not looking at the back of the heart with this, then you'll never understand, right? So it's these foundational concepts that people really need to break down in a little bit better of a manner. Okay, about 3 hours and then teaching ACLS. Yeah, it's not enough because ACLS, it's not enough, right? So it's the perfect storm. It happened and most of us didn't know it. While we were all eating turkey around Thanksgiving, there was an article published November 15th, 2022. And basically it gave us all these new STEMI equivalents. And so the pink elephant in the room is just that a lot of us, and I think about it, don't say it, right? But think to yourself, a lot of us don't know what a D Winters T wave is. We've never heard the term Wellens warning, let alone hyperacute. Almost every time I bring up these topics, people are like, yeah, I've never heard of that before. So I don't think that's a failure on you as a provider. I think it's a system failure, and that's the pink elephant in the room. And I don't want to bring up all the system failures, but just know that instead of knocking yourself, right, it's a system issue. And once you can kind of get past that it's you, it's not you, then you can kind of move through and learn the process. So chest pain is so common, right? We're going to see it in the ED. It accounts for 7 million ED visits, but we also see it everywhere else. And so even though we want to avoid it when we work in primary care, it's not going to happen. And so we need to be armed with the tools. And this is one of the tools. So this is the article I've been referring to tonight. If you wanted to look it up, it's a practice guideline. And basically, as I said, it was this decision on how to dispo acute chest pain in the ER. But when I sat down and I read it, and guess who else is reading these articles too? The lawyers, right? Who want to take us to court and take our licenses and take our homes. They're reading it. But when I sat down, I read it, I was like, oh, this is a game changer. And to be honest, I've been teaching these findings so if you've taken any of my courses before, you probably know these findings. I've been teaching these for a long time. But what I used to tell people was these are like STEMI precursors. And now they're being labeled as STEMI equivalents. Okay. And so Michelle had never heard of Wellens either, and 37 years in the CVICU, and she teaches 12 leads. So there are new concepts, and that's what we're going to be bringing up tonight in this article. So again, it doesn't matter where you work, it's for you. But Gus, especially for you, because I think you're our one ER person here with us tonight. Okay. So what you don't know can hurt you, whether you work on the ambulance, it doesn't matter where you work. Okay. So recommendations, let's really dig into this. ER and AMBO, Tina. Yeah. So that's a dream job. I love that. So anyway, recommendations in this article, I pulled out a couple for us to focus on. So here's the first one. In the absence of ischemic ST segment elevation, the EKG should be examined for other changes. Okay. And you're looking for things that are associated with coronary artery occlusion and should prompt emergent angiography. Okay. So we're going to talk about what those changes are, because here's the great total tragedy. They teach you look for STEMI or no STEMI. What about all the rest of the stuff in between that's a STEMI precursor or STEMI equivalent? What about that? That is what we're going to focus on. Now, recommendation number 2 is that this basically says if you're not sure, consult an expert. Do you really have that available if you're in the primary care or urgent care? No. You can in the ER, right? You can absolutely elevate it to a cardiology level, but we don't have the luxury, right? So what we need to do if we're working in the outpatient setting is take advantage potentially of serial EKGs. So this is something that we probably didn't do before because we were scared of it. We didn't want to cost too much work, but you can sometimes detect changes within a few minutes on an EKG. They're called dynamic EKG changes. So you can even do this in primary urgent. You can leave the patient in the room with EKG on, go see another patient, have your MA go in and do another repeat EKG in like 5 to 10 minutes. And this would be in a scenario where you're not sure, or the patient didn't want to go to the ER if they were having chest pain. And you were like, I don't know, it looks a little abnormal, but let's just do another one. That's a scenario where you could potentially utilize. And then the third recommendation is that if you think there is potentially a posterior MI, you should perform a posterior EKG. So what would you look for? Let's have you guys participate. Not in a rural area, Tina says. Yeah, that's true. That's a very good point. So what would you look for? And Tina, you almost have to be better. You have to be like 5 times better because you're rural and you don't have the resources. So what would tell you to do a posterior EKG? What EKG finding? Does anybody know what EKG finding you would be looking for? Depression. Absolutely, Amanda. Good job. Yes, depression in V2 and V3. Hey, John, what's up? John's EMS also. So ST depression, Michelle, yes. Depression in V2 and V3. Okay, perfect. That's what we'd look for. If we see that, we can go ahead and run a posterior EKG, which is a V7, V8, and V9. and we'd be looking for only 0.5 millimeters of ST elevation. Okay, that's how to know the posterior wall is in trouble. So this is just things we need to keep on our radar. So essentially, when things were already hard enough, they sort of just made it harder for us. And here's the Grim Reaper coming for our patients all the time, and hopefully we can get ahead of that Grim Reaper. So here is kind of their little algorithm. And I just want to bring in a point here for you to focus on in this. So essentially, they're really wanting to focus in on these two things, okay? So other findings, and we're going to give you a list that are concerning for ischemia or infarction. And then also, we're looking for the ischemic ST depression, okay? Or we're looking for elevation in AVR with multi-lead ST depression and also Wellens. So they really want us to know these and be able to identify. And I'll show you some examples of these. So essentially, we went from a STEMI nation to we need to not be a STEMI nation anymore, right? We absolutely need to look for the other things as well and all the gray areas in between. So it's a paradigm shift. And if any of you really want to nerd out on this, and let me ask you before I tell you, has anybody heard the term OMI before? OMI, very few people will have heard that, but occlusion MI is a new term it's not that new, but a lot of you will not have heard it. And there's a paradigm shift to that we're looking for occlusions of the coronary arteries, not just STEMI, okay? Brandy says, can you send a link to your PowerPoint or the 3-article guideline? Yeah, you can actually just Google the article, it's all in there. I'm just pulling these out from there. And we can't disseminate it actually. We're not legally allowed to, but you can Google it into your own device and you could print it if you want to or download it. And it's open source, so you don't have to pay for it, which is great. Okay, so some of you have heard OMI, but there's a shift to looking for OMI occlusions versus STEMI, okay? There's a big time shift. And so that's where we're going today. It's going from a long time ago when the earth was flat to basically going to where the earth is round. So are you ready for the big reveal? Yes. That's also on the same playing field, Amanda. Oh, Lisa, you put the article in. Thank you, Lisa Ma. Thank you. I was going to do that when I got off, but you're saving me. So let's do the big reveal. Let's talk about this article. Okay. Here is the table I pulled straight out of it. This is what I call the hot list. So here, just to orient you, this is a busy slide, I get it. These are the STEMI equivalents. So things that are on this side here are all things that are STEMI equivalents. So this is easy, posterior STEMI, okay? We already talked about that, depression in V2 and V3. And we talked about, and scarbosas you already knew, that was already something that wasn't hard. We already knew scarbosas was an issue. But then there's 2 other things maybe we haven't heard of that are STEMI equivalents, which is D Winters T waves, and I'll show you those, are D Winters sign, interchangeable basically, and hyperacute T waves. So the definition of this is here, the hyperacute, it's a broad peaked T seen in early STEMI, okay? They will usually progress on within minutes, no more than like half an hour onto a STEMI. So that's why they've now put them in the STEMI equivalent. So I'll show you a case where we actually had that happen at the end. And then D Winters are basically ST depression in V3 and V4 with hyperacute T waves. Okay, so that's the STEMI equivalents. Now, the other findings on the bottom, we mentioned Wellens syndrome earlier, or Wellens warning, again, interchangeable language there. That's basically a biphasic T in V2 and V3, and a T wave should never be biphasic. Should never go up and down, okay? And then you also have inverted T waves. So they're putting this on the menu. And this is basically like, get them to cath soon. Not a STEMI, but get them to cath like very, very pronto. And that can look different in different settings. And so you can always consult like your medical director, right? Or whoever you work under. But basically, if you have somebody with any of these 4 findings, hot potato patients, let's make a decision what we're going to do. They shouldn't go sit and marinate somewhere, right? So if you have people with inverted T waves that are symmetric, we worry about ischemia. If you have somebody who has widespread depression, which is the second line here, plus 1 millimeter at least in AVR of elevation, a lot of times that's either a multi-vessel coronary artery occlusion or potentially someone needs CABG or just an LAD occlusion. But either one of those is bad. So yes, here's the list, and you can get this table straight off that article and download it so you have it on your device, of course. But I'm going to show you kind of a little bit more details on this. Okay, so the LAD, hey Tanya, you just joined us today. Welcome in. So the LAD tries to tell us it's sick. Okay, so Lisa, yeah, good question. It's going to depend. What you want to do, and what I recommend for you is take this article, download it and bring it in to whoever you work with and be like, hey, so I understand these are STEMI equivalents on the top here, but if I see one of these 4 things on the bottom, what do you want to do? How are we going to approach this? And have that discussion before you get into that scenario. Okay, that's what I recommend you doing. I will just tell you there's varying practices still with that, but you'll at least have the guideline in your hand and you can have the discussion. Okay, because I can't legally say what you should do. I can just show you the guideline, have the discussion. Okay, so the LAD is always trying to tell us if it's sick. Lisa says, collaborate with my doc. What a concept. I know, right? Okay, so again, the question you're always asking yourself is who should go to the ER, and the machine won't help you. So obviously, we just talked about this. I mean, where I work, Wellens Warning is going to the emergency room. They can be pain-free or not have pain. They're still going to go to the ER, right? If you have elevation in AVR with widespread depression, you're going to the ER, friend. ST depression in V2 and V3, I'm looking for posterior, and you're going to the ER. And if you have a posterior, like I'm slam dunking it without even doing a posterior, so that would be like massive ST depression in V2 and V3, you're going to the ER. So there's lots of little things, and here's the real scary part. None of these are going to say what they are. The machine's going to say non-specific ST wave changes. Okay, so that phrase should bring fear down your spine, because when you see that, look for these things is the moral of the story. Okay, and look for, when you're thinking more globally, not just about tonight's talk, look for all of these things. All of these things are game changers, okay? Things that can have serious consequences. So when we go back to the beginning of the class where I said, hey, you really want to know the normal things, but then you really want to take any precious time you have to learn EKGs, and you want to focus on this list. So in this list we're talking about these tonight, but there's all these other things too that you need to throw on your menu to really focus. But this is great, because if you're thinking to yourself, well, when I start learning about EKGs, I get really overwhelmed, and I don't know where to start, and I want to give up. Well, here's the place that you're going to get the most yield, right here, the most yield, because if you know these things, you'll kill less people, right? By picking this up. So, like I said, don't focus on, so people, this is the problem. Okay. When I work with one-on-one students and I say, okay, look at this EKG and tell me what you see. And people actually let their guard down, where they know I'm not going to judge. And I hear what actually they're thinking. They're like, oh, well, I see, over here, this P wave looks funny. And over here, and they focus in on something that catches their eye. What I notice is that they're focusing on things that really don't matter, or like the axis is this or this. And I'm like, but meanwhile, they have a STEMI, and you miss the STEMI. So we need to focus. Now I know where your mind goes. We need to focus on STEMI. So that's really, check your own thinking, make sure you have a 10-step system, and you can go back to watch on the replay page. I think day 3, we go over a 10-step system to help you not miss these things, but have a system so that you don't miss them. Try not to just go to the most beautiful thing on the EKG, because we've all done it. We've all been there. I used to do it too. And I have such bad ADHD, I have to keep the blinders on of my 10-step system, because I get in the same boat. So anyway, how am I supposed to learn all this? Well, I just gave you a list of the things that are the most dangerous, right? And then we're going to show you some examples tonight to get you going. So number 1, have a really solid handle on your waves. Know them. Understand the size of them. There's a lot of clues your P and your QRS can give you but ultimately it's the T's that are the most important. And we covered some of those, a little bit of that in the first night of our 3-day EKG challenge, but ultimately here's the take home. So you don't have to go find that and rewatch it, okay? The T waves should be upright in all the leads except for AVR and V1, okay? Everything else should be upright. If they're not, start thinking about the bad things, okay? Ischemia, LVH can do it as well, left ventricular hypertrophy, but know where they should be upright and that they shouldn't be too tall or too small, okay? Super important. And so we basically need to learn as much as we can about the T wave. And so if you think about it, when we fall in love, we learn everything we can about that person, right? The other person, we get all the details, maybe we research them to death, right? What can we find out about them? I want to know all the things. We need to feel that way about the T wave, because that way we'll be interested to learn all the things. So again, you want to make sure, right? Here's Cupid trying to make you fall in love with the T wave, just like I am in love with the T wave. Not too pointy, not too big. Those are two really critical things also, in addition to the way they point, right? The direction, they also have to not be too big or too pointy. If they are too pointy, you think about hyper K. If they're too big, you also worry about ischemia. So always looking at the size is important. And then of course, upright, we talked about this in all the leads, except for AVR and V1. And they should be a little asymmetric. A symmetric T wave is never good, okay? And we got to think about the mom, dad, baby analogy. So here's how this works. You've got the R wave, which is the dad, you've got the baby T wave, and you've got the mom P wave. And they should all be holding hands together, okay? And you also need to understand, when you think about this, this helps for heart blocks especially, but when you think about the T wave as the baby, you need to understand that your baby is going to be one of the smallest members of your family. And that should be true in every one of your complexes, okay? That should always be true. So if it's not, then you got to think about the problems. So what other waves do you need to know about? You need to know about the Q wave. So a Q wave is a really deep deflection that's negative after the P. And if it's deep or wide, we have to worry about them. So usually 1/3 the height of the R wave. It can mean there's old MI, right? But it can also mean other things like pulmonary embolus, which we won't deep dive into today, but just know that a deep or wide negative deflection is also something to put on your radar to be worried about. So here's how it works. If you have a wide one, it's pathologic, meaning bad. If you have a Q wave that is 1/3 the height, you can see this is the R. You're cutting it up into thirds. And this is the third, the height of the R wave. So it's therefore pathologic. You're always measuring to see how deep it is, to see if you need to worry about it, okay? And just a little side note to put Q waves a little higher on your priority list. A Q wave can form within an hour of an infarction. So if you have an EKG with a Q wave, you can't say old MI all the time, okay? You can't unfortunately say that. It could be a new one. So what does that mean? It means you need to worry about them probably a little bit more than you already are. Okay, number 2 rule to help keep you safe is don't trust the machine. It's a robot. It was programmed by people that don't have all the nuances that we have as humans. And in this respect, at least until AI gets involved, which I think is coming anytime soon, like a more advanced AI for the software, it's all on us, okay? So machine will sometimes tell you something's normal and it's not. It'll tell you something is an MI and it's not. So ultimately, we still have to know how to read our own EKGs, okay? So the machine software, here's another article if you wanted to look it up, it's not really accurate. So it's anywhere from like 6 to 42% of the time it's accurate. It isn't very much. So you have to be able to trust you. And, you know, they did this article where, you know, they had a bunch of false negatives, false positives. You can read that here if you want to pull it up from that article. But basically, just don't use it. Don't rely on it. You can help let it guide you, but just don't rely on it. Actually rely on yourself. And the reality is also that they did a big study where they compared, you know, cardiology versus ERMD versus paramedic, and nobody got 100% right as well. And so the take home on that, this stuff's pretty difficult, okay? So before you go knocking yourself for not knowing it, it's difficult for everyone, okay? So here's an example of the machine saying, this is normal, a normal ECG. No, it's not. No, it's not, friend, because first of all, that T wave is inverted and symmetric. Remember, we just said everything's supposed to be upright except for AVR and V1. This is inverted. And we also have a short PR interval, which is not normal. Okay. So as Robert said, machine should always just be a guide. Absolutely. So this PR is shorter than 120. That's abnormal. This is not a normal EKG. There's an inverted symmetric T wave here. Okay. So no, it's not normal. And this one too, this is an EMS one. Okay. It said normal EKG. And that last one was a hospital. This is an EMS one. But this T wave is inverted and symmetric in AVL. And this T wave is upright. And there's actually a right bundle branch forming here. You don't see it yet, but it's coming. And those two things are not normal. These T waves are also a little bit bigger than they should be. So that's this guy STEMIed 5 minutes later. Actually, no, it was 4 minutes later. Okay. So you have to be really careful because the machine is just a machine. And knowing these rules really does, as you can see, come in handy. So now let's take it and let's do a little practice together just to kind of like run through a few of these and see if we can't pick up the findings together. So here's a case. This is not a real patient's face, but he's got some chest pain. You can tell that because he's, of course, grabbing his chest. And we're like, okay, so if you're in our clinic doing this, pretty much don't care what your EKG says, right? We're going to send this patient to the ER so they can be screened. But in the meantime, we're going to get an EKG. And you can see here that what you've got is a very subtle finding. Okay, this was not called a STEMI by the machine. Okay, so this has some ST elevation in 3 and AVF, which are inferior leads, and it has some ST depression, which is found in 1 and AVL, which are reciprocal leads. So in order to have STEMI, you need to have 2 leads with ST elevation and 2 leads with depression. Do we meet criteria here? Yes. Did the machine call this? No. So this is why you have to keep your eyes wide open. And my recommendation to always do that is to take and make a straight line across all your ST segments every time. And if you're wondering, do I still do it even today, now in cardiology or wherever I work? Yeah, I still do it. I did it on the ambulance. I still do it now because it's the subtle stuff like this that will bite you if you don't do that, especially as you get older and your eyes get a little bit more fuzzy as you go along. Okay, here's an example of somebody with some very minor ST depression in V2 and V3. Remember, we said that that was concerning for posterior MI, remember? So this guy, you could absolutely do a posterior if you wanted to while you were calling the ambulance, if you're in the clinic, right? And you're calling the cath lab if you're in the emergency department, because this is a posterior MI. And be very wary of people with indigestion, okay? I have to tell you, there's a triage protocol in place, at least at our emergency department, where if you have anything from like, you know, they say neck to navel, anything weird, we're getting an EKG. And it's really saved some hallway MIs before, right? Where you think it's a gallbladder and then they're basically infarcting. We're thinking it's GERD or a gallbladder when an EKG just could have been done. So have a low threshold to get an EKG. You'll be surprised at what you find. So let's do another case. This is Roberta, and this is not actually a real patient's face, but this was a real case. Okay, yeah. Thank you for putting that in, KJ. Welcome in, welcome in. So Roberta is 89. She's having some feeling weak and some chest discomfort. And so she goes to the emergency department. Blood pressure is kind of high, and this is what they see. So this patient actually had some of the findings that we chatted about earlier. She had a couple of them. So here you can see her T waves are inverted and symmetric. Okay, so we know that we have to worry about ischemia with these T waves, because remember, they're supposed to be upright in all the leads except for AVR and V1. But if you look in AVR and V1, they're actually upright. So they're not following the rules either. And then here's an example just to show you of what let me get my pen, what a biphasic T wave looks like, okay, where it goes up and down in the same lead. That Okay, that's biphasic when it goes up and down. It's a wishy-washy T wave. So this patient ended up going to the cath lab and she had completely clean coronary arteries. This was a surprise. Turned out she actually had Takotsubo's cardiomyopathy, which is broken heart syndrome. But believe it or not, this is rarely found when you don't have a coronary artery occlusion. Should you ever make that diagnosis on an EKG? No, right? But you always, when you see this, want to be worried. And these T waves like this, you want to be worried and send them to wherever you need to send them to get them evaluated. Okay. So she ended up having what I called Takotsubo's. Her ejection fraction was 32%. And so, obviously she's going to recover in a, couple of weeks to a month on maximal medical therapy, right? To improve her ejection fraction. And she's going to be told to de-stress, right? Like stay away from stress. So Brenda says, will this be recorded? It is being recorded and will be available to watch later. Yes, because I know we're covering a lot of things. Now, this is another case. This is not a real patient's face, just a disclaimer of a person who had chest pain. He's got one kidney. He has diabetes, hypertension, hyperlipidemia. And he says, my pain is worse today. So his daughter says, please go to the hospital, Dad. He says, no, the COVID is there. Okay. His pain, it's worse when he walks. So it's exertional. It's a pressure. It goes to his neck. It's 6 on a 10. And he's had it for 3 days. So pretty much, I don't know about you. I don't care what his EKG says. He's going to go to the emergency department because he needs to get worked up. This is somebody who's got one kidney and has very concerning story for chest pain. So here's his EKG. And essentially there's a lot going on this EKG. But what I really want to have you hone in on is that he's got these inverted T waves again, where they shouldn't be. And this here is an example of hyperacute T waves. They're too big for their R wave, okay? And this one right here in V4, he actually also has a biphasic T wave. So when you put all that together, where is he gonna go? Gonna go to the ER according to our new consensus document, right? This happened before the document and he went straight across to the emergency department. So what happened? So he got a stent in his circumflex and his left anterior descending. Okay, that was 2 places we had hints of problems anyway. And he ended up getting 2 stents. Now think about this. What also is brewing in the background, this isn't really EKG related, but if you've got one kidney and we just put a whole load of contrast on that one kidney, right? No good, no good. But the story, this is a real progression. Unfortunately, the next day, as he's recovering in the heart center, there's a rapid response to his room. And he says, oh, my chest hurts again so bad. So they do an EKG. He again has a STEMI. How is that possible? Well, his arteries re-occluded. So they took him back to the cath lab. They re-stented his circumflex, but they could not open his LAD. So now his heart's not perfusing very well and his ejection fraction is very low. And he now has heart failure and contrast-induced nephropathy from 2 loads of contrast onto that poor kidney. So time is muscle is the moral of the story. And unfortunately, this story didn't end, okay? The next day, rapid response to his room again, because he had palpitations and said, I really don't feel good. Well, his ejection fraction was very low. So you know what's coming, this rhythm here, right? So this person went into ventricular tachycardia, which isn't uncommon. And it's why we put in ICDs into people when they have low ejection fractions and they stay low. So this patient had an EKG that was just a nightmare, but only really said on its top reading, non-specific ST T wave changes. So if you just relied on that and you were like, well, it's non-specific, so I guess you can go home and follow up with cardiology. Think of how many times that happens a day. I'm pretty sure it happens a lot. And this guy would have died that night at home. He has in front. So after that EKG was taken that I showed you, 5 minutes later, when the second EKG was taken, he was already code STEMI. So those T waves, those hyperacute that are tall, okay, they really, really matter. So it really is worth knowing this stuff. And I totally understand why they made this guideline decision that they did. So then this is an example of the other finding where you've got this, and this is more of a non-specific one, kind of harder to tell, but the machine said non-specific on him. And again, the key really is drawing out your ST segments. Okay, you're drawing out your ST segments. And what you're going to notice is there's a pattern of widespread ST segment depression. Okay, widespread ST depression. And when you go back up, whenever I see this, Cam, I'm going to encourage you to do the same thing. Whenever I see like a bunch of leaves that are not contiguous, okay, but are not together, fed by the same artery, I always go back up. So this is literally what my mind does. I go to the EKG and I like draw out all my segments. And I'm like, okay, that doesn't make sense because this isn't the same as this artery. This isn't the same as this artery. Okay. So either I have a multivessel or, and I literally take my eyes, and this is where my eyes go. They go right over here to AVR. And what I'm looking for is more than 1 millimeter of ST elevation in AVR. That was on the second half of that checklist as something that needs urgent revascularization. There has been many cases that have had cardiac arrest while waiting for an outpatient stress test with this finding. Okay, so that's why they say do something soon. Okay, urgently, emergently, right? They're not a STEMI, but get them in. And that's why this was an LAD occlusion. Now, this is another one, just kind of to share, another great case in practice where you had somebody with, and we talked about this earlier, Q waves. She's got a pathologic Q in lead 3. We know that because it's halfway, or it's a third of the R wave, right? When you see that, it's pathologic. So we need to be concerned about it. Now, this lady at 24 years old got 2 stents, and she's 24. Now, why did that happen? And why was the Q wave the only thing we were seeing? Well, sometimes that happens, right? Sometimes the EKG doesn't always match the findings inside of the heart. And sometimes the age doesn't match what's happening. But we have to look at the patient's heart age, not their chronological age, the heart age. And if you knew that she was diabetic, insulin dependent, and had hypertension and anemia of chronic disease and hyperlipidemia, that's a heart of a 70-year-old. And so our threshold would have been really low to get a workup on her, right? So you always have to kind of put that into perspective as well, because people will say to you, why are you getting an EKG on that 24-year-old? 24-year-olds don't have heart disease. Well, I'm not looking at the external package. I'm looking at how much oxidation is happening inside this patient, right? And what her family history is. And there are people who are like, well, my uncle died at age 30 of an MI. Like, you're not a 24-year-old in my mind anymore, right? You've just elevated. And if you're complaining, I'm really concerned because you're genetic carbon copies of your parents, okay? So let's take a little quick survey. Which one are you most excited about implementing? We've almost been an hour now. Which finding are you most excited about? Are you most excited about Wellens or De Winters, or what are you most excited about, right? There's all sorts of things. Hyperacute T waves. What are you going to go out and start looking for tomorrow or even tonight if you work night shift? So if you want to learn more about these findings we talked about tonight, we actually have an opportunity for you. All of them, yes, Brandy, Wellens. I know Wellens is exciting. We have an opportunity for you this weekend to continue learning some of this stuff with us. So if you don't want to take that list, Karen says T waves, if you don't want to take that list and go sit down and try and learn these on your own, and you kind of want them put into like a condensed 3-hour format for you and just want some guided practice, we have an opportunity for you to do that this weekend. So we're going to take and condense your time. Love the T waves, Michelle says. Sandra says Wellens. Oh, hey, Sandra, I haven't seen you in a while. So we're going to focus on, in 3 hours, just learning the most important things. We're going to take out all the fluff and focus on that list of the high risk things. We're going to cover all of them. And we're also going to spend the second hour dedicating to just the findings we talked about tonight on the hot list. So we put together a course. It's a 3-hour workshop. And we're going to do it on the 19th from 9 to 12 Pacific Standard. Oh, hey, Snarfly, what's up? And so we're going to do that on the 19th, which is Sunday from 9 to noon. It's going to be recorded. And we're going to also do a hands-on. I have a big heart. I show you kind of my anatomy demo and how it corresponds to the 12 lead. We color code the 12 lead together so you understand contiguous leads and reciprocal changes. We also talk about the non-specific ST2 wave changes in hour 2. And then the last hour, we spend just doing hands-on our 17-12 leads. We go hands-on and we really get dirty in this and just really understand these findings so we have a solid foundation. Okay, so you're going to get this class on Sunday with 3 hours of category 1 CE should you want to join us. But also you get access to a learning portal. Hey, Penny. Yes, I'm glad you're here. We have a ton of bonus things in this particular EKG workshop learning portal. There's Scarbosa's if you want to learn about that. There's an actual 3D model. There's extra, bonus lectures, all sorts of snacks. Hi, Keiko, that are in the portal, as well as a cardiac exam ebook. And there's a bunch of solve the cases where you watch over my shoulder. But the best part is going to the live workshop Sunday from 9 to noon. So if you guys want to join us, here is where to go. Yes, Dina, we would love to have you. And Heidi, CEUs, yes, for RN, PANP, and EMS. That's who we have CEs for. Heidi says she's an ER educator. Oh yeah, you would definitely benefit from this. Sandra Baus, yes, you would love this class too. You sign up by going to Conquering Cardiology, and we actually normally, we normally have this class for $75 on our website, but we discounted it for the next couple days only down to $49. So you get everything in that workshop portal, and you get access to the live class plus the recording of it on Sunday, March 19th, for just $49. So it's a smoking hot deal. And now let's talk about the prize. And I'll be around tonight if you have questions. If you want to know if something particularly is covered, I can go over it for you. But let's talk about the prize. Oh yeah. So we actually give you the like the hands-on class with me in a Zoom. Then we record it and we put it in the learning portal for you to watch. So you have access to it forever. You can watch as many times as you want. There's already if you sign up like right now, there's already a recording of that class if you wanted to like watch it tonight. But we put, each recording in there. So like you can watch your own class that you did so you can refresh. So that's kind of cool. So tonight's prize, and here's Remington, and he is going to be, so the hashtag is going to be hashtag Remy. Okay, hashtag Remy. And again, what we're going to give away, like I said, these are not made anymore. Okay, I've never given one of these away. I never have before because we don't have anymore. But this is an excellent opportunity for those of you who are live till the end. You get a chance to win this. So if you want to win this MI window that has the color coding overlay, you put in hashtag Remy on either Zoom or Facebook, and I'll come back in tonight and we'll draw the winner from your names. We'll be announcing. And of course, if you have any questions, you can let us know. But I think we got you. And guys, while I'm on just for a few more minutes, let me know if there's any questions that have come up for you tonight or anything I can answer for you. Yes, it looks like, I think Marla, you had your hand raised. Martha? Go ahead and ask if you have a question.
I was in error.
Oh, okay. All right. No problem. So fair enough, you guys. If you don't have any questions, we'll be seeing you a little bit later. We'll announce the winner in our 3-day EKG challenge group. Thank you all for coming. The link Fiona wants for the 3-day. Yes, we'll get that for you. We'll post it in the 3-day EKG group as soon as I hop off. We'll give you the replay link for that. And then this replay will be up in the guide section. But just let me know what you need. We're happy to help you guys. And we'll see you in a few to announce the prize. Can you message me on Facebook? Yes, at any time with questions, absolutely you can. Oh, hey, Doreen, what's up? Hey, Tommy. So we'll see you guys in just a few after we announce the winner. Good luck to everybody. And if you're joining us, just to let you know, what's going to happen is once you sign up, I'm going to send you an email with the Zoom link. I'm going to send you your printouts that you're going to print out for our class. And what I want you to do between now and Sunday is to get some crayons. Get some red, blue, and green crayons. Remington just walked in. Hey, Remy, you want to say hi to everybody? Come here, Rem. So you want to get those crayons together. You want to print out your stuff, and we'll be meeting on Zoom from 9 to noon on Sunday. We'll go through all the things together, and we'll get you super confident with these high-risk bindings. Okay, I think that's all for questions. Have a good night, you guys. We'll see you in a few with the winner. Okay, bye.